seconds here. Feel free to put your name in the chat. We're also going to take a poll or two asking who all is on the webinar this morning. In addition to that, feel free to put your name and your organization into the chat. We would love to know who's here. So I'm just going to read a blurb regarding the Wiretap Act. So in accordance with the Wiretap Act, it's against the law in Pennsylvania to record oral conversations without the permission of folks involved in most circumstances. This session is being recorded for training and or record keeping purposes. And by participating in this session, you are consenting to the recording, retention, and use of this session. At any time, if you have a question or comment, feel free to place that in the chat and we will respond to you. Excuse me? And we'll respond to you as soon as possible. So if you don't wish to be recorded on this call, please go ahead and exit the call. You will be able to review the video in its entirety on the DDAP webpage following this event. So we'll go ahead and get started. ASAM alignment. The alignment of the ASAM criteria is required of treatment providers, as well as for providing treatment services under agreements with single county authorities and managed care organizations. DDAP strongly suggests reading the ASAM text in its entirety, attending the ASAM training, and review the resources available through the DDAP documents and training. These are our learning objectives today. I am joined today by Scott Boyles from Train for Change. Scott is assisting DDAP with the next 3 ASAM webinars to help us navigate some of the nuances of ASAM. We also have various members of the DDAP team to support us if we need anyone to jump in. But first, we're going to go ahead and run a poll. So Amanda, if you could put the first poll up, I would really appreciate it. Would like to know what your role is within your organization. Looks like we have various individuals, SCAs, MCOs, some DDAP, some counselors, clinical supervisors, clinical directors, a couple executive directors. Leave that up for another couple seconds, give you time. We'd love to know what your role is at your organization. SCAs are represented. Okay, great. We have a little over 100 responses. Thank you. Then we're going to go ahead and run another poll. We'd really like to know what measures your agency has in place to assure the fidelity of the ASAM criteria, or to the ASAM criteria. So 1 would be not very clear at all, and then 10 would be very clear. And we're not, we're just trying to get an idea of what organizations have done so far. This isn't a test or anything. We'll give it another few seconds for people to respond. Okay. Couple tens and nines, some eights. Great. Thank you. Um, so we'll go ahead and move on. Before we get into the content for today's webinar, we just want to remind you that it is important to be familiar with all regulations and contractual requirements, especially in areas that intersect with the ASAM criteria. Today, we're going to discuss, we're going to touch a little bit on staffing, which does intersect with chapters 701 and 704 regulations, and recently Act 66 of 2023. And so it really is a really good idea to become as familiar as possible with any regulation that intersects with ASAM, and we'll probably get into a little bit more of the intersection of different criteria, and as we get into more of the vague areas of ASAM. So we'll go ahead and get started. I just have a couple slides to go over before I pass the baton over to Scott. Uh, Last month, we talked a little bit about clinical services and what services meet the threshold of being considered a clinical service. So first, we'll start with the role of a counselor. So in addition to Pennsylvania's staffing regulations, all clinicians hired after July 1st of 2021, all clinicians hired on or after July 1st of 2021 must be credentialed or working toward credentialing. According to the ASAM criteria, the third edition, page 417 defines a counselor. A counselor is an individual who is trained to give guidance on personal, social, or psychological problems. This training in areas of substance use disorder and mental health counseling is a distinct profession that hold national standards for education, training, and clinical practice. DDAP acknowledges counselors as both credentialed counselors and those working toward credentialing. It is important that counselors work within the scope of their practice and use referrals for treatment plan needs that fall outside of that practice. We hope to get a document posted to DDAP's ASAM transition page listing the different credentials and credentialing bodies that you can use as a resource going forward. Again, we get a lot of questions about what services are considered clinical. So clinical services are those services that are provided by an individual who is staffed by the program and meets the previous slide's definition of a counselor. Skilled treatment services are those services that are supporting the person's recovery, such as medication management, occupational therapy, recreational therapy, and educational groups run by case managers, recovery specialists, or external providers. So it is important to know what the ASAM criteria calls for the level of care that you provide in terms of the types of services. For instance, levels 3.5 and 3.7 levels of care specifically call for daily clinical services. So that means that someone who meets the definition of a counselor must provide those services. Good morning, Scott. I'm going to pass this off to Scott at this time. Does anyone have any questions about anything that was discussed so far? And put your questions in the chat and we will address them during the webinar like we did last month. I can't see if there's anything. Doesn't look like it. So without further ado, I am going to pass this off to Scott Boyles. Thank you, Scott.
Good morning. Thanks for having me. I've had quite a challenge for the last 30 minutes just trying to connect, and sorry my camera is, you may or may not know, it's not how I typically would hope it to be. So thanks again for having me, and thanks for the nice introduction. We're going to jump into a few things that were brought up as a result of the last session we had. And as always, if you have additional questions, please feel free to jump in. And one of the things we're going to talk about today is individualized care. And we love to talk about individualized care and patient-centered services and individualized treatment plans. So we were just going to touch on some kind of basic things and considerations you might ponder in an effort to get a little better at individualization of services, or this might also help validate your brilliance and your good work with individualizing services. Obviously, different providers and different programs are in different places in this continuum of the individualization of care. And there's certainly lots of challenges to individualized care. And at times, I think we talk about it so often that it kind of gets lost as what in the world does it look like? So we're just going to touch on a few simple things here in the concept of individualized care, and especially thinking about just the design of individualized care. We deliver what we're designed to deliver. And just like when we work with the people we serve, I always like to think, we help them redesign their lives to support new behaviors. And we're hopefully really good at that. And that's a kind of a system thinking approach where we're redesigning structures, lives, or structures within the context of their lives to support this behavior change. And conceptually thinking about individualized care, it's like, are we really designed for individualized care? Is our program, like when we sit with the person served, designed to develop an individualized treatment plan? And there's some things we do that support that, and then there's some things that we do or that we're a part of that might be barriers to that. And I'm just going to hit on a few here. Historically, programs have standard activities, like what makes you a program? Well, we're a program because we offer this and we offer this and we offer that. We're a program because we have a belief in a certain model of care or a certain type of care. So within the context of that, we offer standard program activities. Sometimes programs offer evidence-based practices. We hope they're offering evidence-based practices and evidence-based services. And within the context of evidence-based practices, there's frequently standardized activities that people need to participate in that evidence-based practice. Ironically, sometimes when we're delivering evidence-based practice, it takes away our ability to individualize services because we're sticking to the model of care. So thinking about standard program activities, does everyone get the same activities within the context of our program? At times, we deliver standard program activities because we're trying to meet state expectation and requirements. The state might say you have to have so many educational hours, or so many group therapy hours, or so many individual sessions per week or per month, depending on the level of care. So sometimes our standard program activities are designed to meet regulatory requirements, which is sometimes much different than designing them to meet the individualized needs of the person served. So sometimes the challenge of individualized care is understanding what kind of standardized activities do we have to have? And in the context of those, are we also leaving room to individualize services based on the unique needs on the person's treatment plan? So how do standard activities impact our space and time and ability to deliver individualized services? If I was in charge of the world, I would say, let's minimize standard activities. And let's really develop the activities for the person served based on their individualized needs. If we do have standard activities, and that's a piece of our program that's not going to change, one of the ways to individualize care is we can think about, okay, here's the standard activities. We know everyone's going to participate in these activities because they're required as part of our program. What's going to be different on this person's individualized treatment plan beyond the standard activities? So knowing that everyone's going to go through these standard pieces, when I look at your treatment plan, that's really going to reflect the unique goals, objectives, and unique interventions for you based on your dimensional needs on your treatment plan. And do we have room for that? Sometimes when we do standard activities, we have so many activities, as I say, sometimes we'll have so many activities already designed and developed for the person before we've even met them. We have our whole program laid out. We know it's going to happen in the first group, the second group. We have our whole program laid out. So do we even have room to tailor and individualize the treatment plan is another consideration. Or have we already designed your program before we met you? So thinking about space and room so we can add and modify literally space and room, both on the treatment plan in the organization of our services to tailor and give additional unique interventions based on the person's needs. So thinking about room. External factors, external drivers. Sometimes referral sources might have certain expectations that you're going to deliver certain components in the treatment service. So again, sometimes states have expectations of certain components or interventions or required number of hours for specific levels of care. Sometimes criminal justice systems have certain expectations as far as how many hours or certain focuses that might need to be addressed on the treatment plan. And there's not like a simple answer to that, but sometimes those external expectations can impact our ability to drive individualized care. And how might we consider that when we're formulating the treatment plan with the person served? And more importantly, how might we consider that within the context of our system, and how might we work with those folks if those are actually becoming barriers to individualizing care? Does the treatment plan reflect our program, or does it reflect the individualized needs of the person served? Frequently, we see the treatment plan reflecting the program. We have our program designed, the person served comes in, and we write the treatment plan to reflect the program. That's in essence backwards. We want the person served to come in, and we want to develop a program for their treatment plan, not make their treatment plan fit our program. And when we're making it fit our program, sometimes that's symptomatic of we have too many things in place already. We have our program in place and we're going to write your plan to fit our program, compared to we have a few things in our program. We know we're going to deliver maybe group therapy. We know we're going to do some individualized sessions. We know we're going to offer some education sessions, but I don't know what you're going to do in group therapy. And that's going to be reflected on your treatment plan as I start to understand your individualized needs. I have no idea what lectures you need. I have no idea. Before you came here, I never met you. I don't know what lectures you need. So part of it, my assessment is going to identify what kind of lectures, or educational components you might need, and that's going to be reflected on your individualized treatment plan. So in theory, or hopefully in fact, is the treatment plan and what we put in the treatment plan for clinical interventions becomes the program. And that's going to look a little different for each person served. Everyone might be going to group, but everyone in group might be working on different clinical issue. We would hope they are. They can't not. Everyone might be going to lecture, but the person who's already been to the relapse prevention lecture 4 times probably doesn't need to go again. So would we put them through that part of our program one more time? Or we might think it's like, wow, this person's already been through relapse lecture multiple times in prior treatment experiences. Is that the best use of their time? Is that the best use of our time? And is that the best use of resources? Maybe they need a different lecture. Maybe they need to be offering the lecture instead of participating as a listener in the lecture. Maybe they need to be co-presenting the lecture. Maybe there's more valuable things to do with their time. We talk about this fancy term. I don't know if it's fancy, but it sounds pretty cool. Shared decision making, and an aspect of developing that individualized treatment plan is shared decision making. We're doing this together, so this is a collaborative relationship. That collaborative relationship, by the way, starts with the problem. So we have a problem, we have goal, we have objectives, and we have interventions on that treatment plan. over the course of that entire treatment plan development, from really formulating what the problem is to the goal to the objectives, should be a collaborative process. I would note that when we're developing that treatment plan, especially when we're initiating, what's the problem? What are you going to be working on in dimension 3? What are you going to be working on in dimension 4 or dimension 5, or whatever those clinical issues arise that justify the level of care? That problem is not just random, like, hey, what do you want to work on in treatment today? But that problem kind of initiates from our biopsychosocial assessment. So we're not necessarily saying, hey, what do you want to work on in treatment? Although that sounds very inviting and very collaborative. We might be saying more, we've identified there's areas around this dimension or this dimension. We may not use terminology around like dimensions, but we say we've identified areas here where you talked about feeling sad and alone, and you tend to isolate a lot and feel like there's a black cloud running around chasing you over the top of your head, which might be like a dimension 3 issue. You talk about being depressed and feeling anxious and really more apt to use when you have these types of feelings. That might be a dimension 3 issue, and that might be a problem statement for dimension 3. So we're kind of helping people through our assessment, and we're assessing the 6 dimensions. As we're identifying the clinical issues in those dimensions, we're then having a collaborative discussion around what we've identified, compared to just randomly say, hey, what do you want to work on in treatment today? Most human beings who show up in treatment have no capacity, and I don't mean this in a negative way, but they don't have the capacity to just articulate what they want to work on in treatment. Most of the time, they're going to say, I want to work on getting off probation, getting my kids back, or getting my driver's license back. We don't work on those things in treatment. Those aren't clinical issues. So part of really meeting people where they're at in this process of shared decision making is also offering them some guidance on what we work on in treatment related to you, which is related to the recommendation for the level of care based on what we identified as part of the assessment. And those issues are going to be reflected in the dimensions. So helping kind of guide that conversation, or even considering it as like, here's a menu of a couple issues or a couple things we identified as part of the assessment. And again, in our world, it would be a dimensional focus. We wouldn't use that terminology with the person served. But what might you like to work on? How does this fit with you? You talked about this in our assessment. I think this is an important piece for you to work on in treatment. What are your thoughts and what are your ideas about that? And that's where one little example, at least, of where we're starting with the focus of what got the person in care, to talk about what they want out of care, rather than just asking people what they want out of care before they've understood why we've recommended care. So again, that conversation comes once we've recommended treatment, not before we recommend treatment. Again, people really struggle when we say, what do you want out of treatment? They're going to tell us what got them there. And what got them there is typically not a clinical issue. I like to talk about in our treatment plan training, what got you to the hospital? A car wreck. Well, a car wreck got you to the hospital. You were in a car wreck, you were sent to the hospital. But we don't treat the car wreck. We treat the broken leg or the head injury. What got you to treatment? My probation officer. Well, we don't treat the probation officer. What are the clinical issues that got you into treatment? What got you into treatment? I got 3 DUIs. Well, we don't treat DUIs, but what are the clinical issues is related to those? So we want to treat and address the clinical issues that justified the level of care, not focus on what got the person to treatment. And frequently when we ask people, what do you want to work on in treatment? They're going to tell us what got them to treatment, the problem that got them to treatment. And their treatment goal is frequently going to be around that problem, which is important because it's highly relative to their motivation. But most often that's not going to be a clinical issue that we're actually going to be focusing on as part of the treatment plan. Deborah, so this is like a wonderful question. It's like a wonderfully hard question. I love it. And just in case people can't see Deborah's question, utilizing evidence-based programs and adhering to the fidelity of them may present a challenge with individualizing treatment. Leaving out parts of the program in order to more fully individualize the treatment plan doesn't follow the fidelity aspect of the program. Can you comment on this? I can't comment on this. I don't have any magic answers. I'd go back to, why are we using that evidence-based practice? Are you using that evidence-based practice because it's part of our program? Or are you using that evidence-based practice because we've identified that that evidence-based practice is best for Scott? If that evidence-based practice is best for Scott based on his individualized needs, then in theory, you ought to be able to stick to that evidence-based practice. If we have an evidence-based practice that we just deliver to everyone and we have everyone go through it, we're probably not using the evidence-based practice as intended. And so moving away from that or individualizing it in certain ways may not be that problematic. A lot of times we see providers use evidence-based practices and just apply them to everyone across the board, compared to, we do an assessment, we understand your needs, and then we identify which evidence-based practice is most appropriate for your needs. And that would be more individualizing that practice. And then I think we could more stick to the model and stay with the fidelity of that practice because we know it meets that person's individualized needs. I would also assume that there's aspects of evidence-based practices where maybe it's just not a good fit. And we may not need to go through that module or that specific piece of that practice because it's not a good fit for that program or that person. And that would be okay. And if we weren't going to apply a certain module or intervention as part of an evidence-based practice, we would explain that in the progress notes as far as why that's not applicable to that person. And that would also be reflecting some individualization, that we're not just going to put you through, I don't know why the term module stuck in my head, but every module or every intervention of a practice, because some of them may not fit. I don't think we're so good that we know that if people go through every single aspect of an evidence-based practice, we're going to get a better outcome. I think there's plenty of fidelity issues already. So I think tailoring it as needed could be appropriate. But if our measure of success or our measure of completion of the program is you complete every module or every intervention specific to an evidence-based practice, then we have a potential problem. And then we have that challenge with that we've kind of boxed ourselves in and taken away our room to be individualized. Because we do see providers, they literally buy, I work for a company that sells evidence-based practices. And sometimes they buy those, and it's like if a person doesn't go through every single one and complete every single one, then they can't complete the program. And if we're in that kind of a situation, that's more of a program-driven model of care than an individualized model of care. And I don't think that's ideal for the person served, nor do I think that's a good measure for progress in care. Hopefully that helps. Thanks for the question. Here's the duplicate. Gloria, I couldn't cut slides for some reason. Every time I cut them, they pop back up. So sorry, duplicate slide. So foundations for individualized care. This again is kind of a little bit of back to some of the basics. And I note too that this ironically is printed in the 4th edition of the ASAM criteria, knowing that Pennsylvania is still using the 3rd edition, but the ASAM criteria is doing a little better at acknowledging some of the more intricate aspects of how we connect with the person served in the context, especially of the assessment process. But again, we're talking about honoring patient autonomy and shared decision-making. Does anyone else, I need some help. I don't like talking the whole time. Patient autonomy, what evidence-based model do we talk about honoring autonomy in? It's one of the most common evidence-based models out there with probably the most evidence ever, and it doesn't come with a workbook. What model of care am I talking about? We talk about patient autonomy. Bueller, anyone? It also has a 4th edition. You can't just come to these and listen. Thank you, Christine. Thank you. Motivational interviewing. Dottie and I work together. I'm sorry, Dottie, I've let the cat out of the bag, so to speak. But yes, motivational interviewing. So patient autonomy, shared decision making, patient autonomy, honoring their right, their ability to make decisions that they believe are best for them. It can be a really powerful way to engage with people. It can also be a great way to help decrease kind of defensiveness or guardedness and improve collaboration. Betsy Duncan is on board also. Being non-judgmental. And I read this morning because I woke up at like 4 in the morning because I was anxious about getting online because I know it would take 4 hours. But I'm thinking hey, by the way, don't be judgmental. It's like, well, duh, of course not. Don't be judgmental. But then I think about some of the terms we use, and maybe you can help me with this. Anybody but Dottie and Betsy Duncan. What kind of terms do we use that sound a little judgy around the office? Not with your coworkers, but around the clients. I don't want anyone to talk, but what kind of words might sound just a little judgy? Oh, I like that. Lacks insight, unmotivated, right off the bat. Really common terms. Resistant, which means they don't think like me. Resistant, yes. Oh, bravo, Christine, you're alive this morning. So manipulative. Just the term problem, even I already used it this morning. The treatment plan, your problem statement. Maybe we should say barrier statement. Refused. I always like that, Vicki. It's like refused. Do you think your doctor uses that kind of documentation? Betsy Duncan refused to have her blood pressure taken. Denial, non-compliant. An addict, yes. If you want to call yourself an addict, that's part of your own gig. That's wonderful, but that can be a stigmatizing thing. Lack of investment, yes. It sounds like a Charles Schwab thing. Lack of awareness and insight, yes. So those could be not only judgy potentially, weaknesses, but that's again terminology that sometimes come up that doesn't always put us in a good position for this thing we call that a therapeutic relationship, and in a place where, you know, how are we going to make shared decision making or be in a relationship where there's shared decision making with someone who's resistant or lacks insight, or is non-compliant. So how we frame our perspective of the person served can be powerful. How we talk about that can be powerful when we think about this thing, as far as this therapeutic relationship. If you don't put in the effort, we can't help. Yeah, come back when you've suffered enough. So again, and hopefully it's like, yeah, they can't put in the effort. Our job is to help them put in the effort. That's what we do. Foundations for individualized care, open-ended questions. Open-ended questions. Tell me about your day. Tell me about your substance use. Especially in the assessment process, I think we can continue to refine our skills around this biopsychosocial assessment. We call it the monster at times because it's so significant in gathering information, and it has multiple questions. But how do we use more of an open-ended question approach frequently to a form or assessment tool that has so many potential for closed questions. And I'm just noting that a person with addiction has one day where they haven't used, and that is certainly definitely a powerful and an amazing thing. So thanks for noting that, Adam. Different levels of readiness. And when we think about readiness, we can also think about this sometimes when internally, when we're thinking about changes or making improvement. What's the program's readiness to change, to really focus on individualized treatment plans or making subtle changes um, around documentation, whatever it might be. So never losing sight, the readiness for change is kind of a nice framework to think about internal change. But when we think about the person served, um, reminded that readiness for change is issue specific. It's not person specific. So it's not we have someone who's a pre-contemplator, as they might be in pre-contemplation around dealing with their marijuana use, but they might be more of an action stage of change around dealing with their opiate use, or maybe they're in action around dealing with their depression and pre-contemplation around their drinking. But really, again, thinking about it's issue specific, it's not person specific. And just also thinking about that readiness for change is not a huge factor in determining level of care. I always think readiness to change is a good way to understand where we're going to meet with the person based on that stage of change. What applicable interventions might be relative to that person's stage of change? So it's really informative as we start to design and develop that treatment plan. As I just think about it, it's like if you have someone who has no interest in playing ice hockey, an appropriate intervention would not be, let's go play ice hockey. I don't know how I came up with ice hockey. They're even thinking about ice hockey. So maybe we need to watch some hockey on TV a little bit and just see their reaction to hockey before we try and get them to play. Someone who's not interested in going camping, we don't try and get them to go buy a tent. We help them maybe take a look at the outdoors and the beauty of the outdoors and some nice sunsets in the mountains. But someone who has, when they come in treatment, they say, I'm here because I'm complying with my probation officer. I think this is BS and there's no way I want to stop doing drugs and alcohol. It's not appropriate to have them go to a relapse prevention lecture. They just got done telling you they don't think they have a problem. So an intervention, participate in relapse prevention lecture, may not be the best intervention based on that person's stage of change at that point in time. So thinking about stage of change and how can that help us formulate where to meet that person in that process of change. If they don't want to go camping, let's not shop for camping equipment yet. They're not ready. Let's help them understand maybe the beauty of the outdoors, and maybe we'll take them to lunch at a nice restaurant closer to the mountains. Fostering the therapeutic alliance, and I thought, man, there's lots of definitions for therapeutic alliance and trying to nail one down. So I kind of went back to the motivational interviewing definition. So therapeutic alliance, mutual respect and trust, which kind of comes back to some of those things we talked about around non-judgmental behavior and what lenses are we looking at this person with to help develop mutual respect and trust. Collaborating on mutually agreed upon treatment goals is a part of the therapeutic alliance. And then really kind of thinking about this therapeutic alliance piece is our developing our relationship with the person served. And in MI, sometimes we talk about, we're in this guiding relationship where we're walking with the person. We're not directing them. We're not telling them what to do. We're not following them, doing whatever they want. Individualized care and meeting people where they're at is not following them around doing whatever they want, but it's really in this guiding relationship where it's collaborative, where we're honoring their choice and their autonomy, and providing options and supporting their own decision making. So different aspects and different ways to think about this therapeutic relationship. What else we got here? Dina noting, run into the terminology of clean, being offensive to clients, considered the opposite is dirty. I know it is referred to in relation to urine drug screens, which makes sense, but I have clients that prefer just defining their sobriety. Yeah, and if you look at kind of like the list of terms, sometimes trying to get away from stigma, the suggestion would be to try and avoid the clean and dirty terminology. Again, if that's the terminology the person served wants to use and describing themselves and their life, that's certainly fine. But sometimes, yeah, what you're noting there, that could sound stigmatizing. Where else we got? Consider the unique personal experiences and worldview of the person served. And this could be kind of broad, but everything from trauma, um, culture, presenting ourselves in a culturally humble way, letting them be the teacher and helping us understand their unique backgrounds, social determinants of health, which is a broader concept. When you think about Dimension 6 kind of recovery environment, we're pretty focused on literally recovery environment and how that recovery environment might affect access to supports or access to treatment or who they live with or where they work. And social determinants of health is kind of even broader than that. And it's really thinking about kind of where people were raised, where they live, where they work, where they play, where they practice religion, where they have fun or practice leisure activities. I guess would be kind of also where they play. But how over a lifetime, how does that impact their health and their health outcomes? And those are additional considerations, especially when not only in the initial course of treatment, but ongoing support and services and considerations as far as how to keep people engaged in services. That social determinants of health framework can help us consider those needs and consider the fact that people just didn't end up in treatment one day. I mean, there's a lot of factors that have impacted their life, and that we might continue to think about how we're going to address those factors, not only over the course of care, but post-care. And these also might be really related to a lot of the case management and potential peer support services we're offering. Significant piece around social determinants of health in the 4th edition of the ASAM criteria, if you want a nice reference. Let's see, how are we doing on time here? 7:44, we got about 16 minutes. We're going to talk about transfer and discharge criteria a bit here. And before we do that, I don't know if there's, or Gloria, is there any questions or anything we may have missed?
I don't see anything that needs to be addressed at this point, Scott.
Okay. So transfer and discharge criteria, and I like to say this is the other 66% of the ASAM criteria, and it frequently gets left out in a way. When providers are using the ASAM criteria, they're frequently very focused in a wonderful way about using the admission criteria to make those level of care decisions and explain the level of care. And a lot of times we aren't as good at really using the transfer. And again, I took out continued stay criteria. We're not focusing on that for the context of this particular discussion today. So we're just jumping right into the transfer and discharge criteria. And our clinicians really using that to support transfer and discharge. And we know there's a lot of factors that can impact transfer and discharge, but ASAM, I believe it starts on page 299 of the book, if you needed a page reference, has pretty clear guidance on how we make transfer and discharge decisions. And these are a little bit abbreviated compared to what's in the book. But there's not a lot more information in the book. This is a very short section in the book compared to the dimensional admission criteria. How do we decide it's time to be transferred or move to a different level of care? They've achieved the goals on their treatment plan. So achieve the goals on the treatment plan. Note, the goal on the treatment plan is your transfer and discharge criteria. This is really important when we're formulating the treatment plan. So if we say, hey, what's your treatment goal? Both the counselor and the person served need to be very, very aware that whatever that treatment goal is going to be one of our measures for transfer and discharge in relation to when you accomplish that goal. So that's where those treatment goals need to literally be treatment goals, things that can be accomplished in treatment. So the quality of the treatment plan, the focus of the treatment goal is key in effectively using the ASAM criteria for transfer and discharge. I'd also note that if they have accomplished their treatment goals, and the criteria says chronic disease management at a less intensive level of care would be the next step. Chronic disease management. With the idea that people don't resolve a chronic condition and that ongoing care, potentially indefinitely, may be appropriate in some type of outpatient setting. So the criteria continues to note and continues to evolve around the fact that the people we serve have a chronic condition, and you typically don't resolve a chronic condition in 6 weeks of intensive outpatient or 28 days of residential or 3 months or 6 months of outpatient, that most chronic conditions are monitored indefinitely to help with support, help address any struggles or challenges the person's having in their own recovery process, and possibly early reintervention if the person needs it. So chronic condition, chronic models of care. Transfer discharge criteria number 2, patients been unable to resolve the problems that justify the level of care. And sometimes people only go so far in treatment. And I think sometimes we can think about this from a stage change model too. They aren't ready to take action. They've gotten the information, they understand possibly their problem, and they might also understand I don't want to change, or I'm not ready to change, or they're only able to go so far in that process. So we've given them as much services as they're ready for. We've given them services relative to their desire and or stage of change. And we're kind of at a stop, which doesn't necessarily need to be a bad thing. It's like you've gone this far and this is awesome. And at this point in time, we don't think we can offer a lot of value for you. So you've gotten, and this isn't quote maximum benefits. This doesn't mean we kept you as long as we can or we kept you through our program, but based on your progress on your treatment plan, we don't see room for additional progress, and again, that could be a motivation issue. So we're going to discontinue services, and we're also going to possibly make referral and or give the person ideas and or recommendations as far as what to do if they want to continue working on their substance use disorder and or other related needs. So kind of maximum benefits, if you will. Number 3, and I think number 3 here is like one of the things that's frequently overlooked. They've demonstrated a lack of capacity due to diagnostic or co-occurring conditions to resolve their problems. Treatment at a qualitatively different level or type of care is needed. And so remembering that sometimes people don't need just more care, sometimes people need different care. I'd also think about this just across the board. If people aren't progressing in care, maybe they need a different model of care. Maybe they're in a 12-step model abstinence-based program, and that's not working for them. So maybe they need a harm reduction model. So when people aren't progressing, we might think about, do they need a different model of care? Also, as noted in item 3, if they aren't progressing, maybe they need a service that's more co-occurring enhanced or co-occurring capable because of their mental health needs. So we need to maybe not just move them to a higher level of care, but move them to a different type of service that maybe has greater capacity to address mental health needs, possibly assess and or offer medications if needed. So people don't always need more treatment. Sometimes they need different treatment. And I think a lot of times when people aren't progressing in a model of care, that we just refer them to the same model, but a higher level of care. Sometimes they need a different model. And also thinking about within the context of a specific level of care, do we have the ability to offer different models, different therapeutic approaches based on the person's individualized needs? So let's go way back to one of the initial slides, and we think about program design. Do you only have one model? If you only got a hammer, everything looks like a nail. If you only have one clinical model, everyone who walks in your program is going to get that model. Which, if we've done perfect assessments and we've identified that everyone who comes to our agency is perfect match for our model, we're good. I don't think that's realistic. So do we have multiple different models to meet individualized needs? And that's going to help us with flexibility and individualization. Patient has experienced intensification of problems. How do we know that? Well, the treatment plan, they're not progressing on the treatment plan. They're not accomplishing the objectives. Typically, we would adjust the objectives in the treatment plan to support change. In spite of adjustments to the treatment plan, if they continue to struggle, or there's just intensifications of problems that are so profound that they're clearly no longer appropriate for the level of care, that would support transfer to maybe a higher level of care, maybe a lower level of care, or again, maybe even a different type of care. And the patient has experienced intensification of problems. Just a simple example is that you're working with someone, maybe they entered treatment as a result of 2 impaired driving charges. They're going to intensive outpatient, and over the course of care on a Wednesday night, they get another DUI, 3rd offense, and they get arrested. That would be a super simple but obvious intensification of problems, which would indicate most likely they probably need a different type of service or higher level of care. Betsy's noting another way when we think about individualization of services, and great point, Betsy. Programs who prefer manualized care models rarely have the capacity to work with the patient who has difficulty with reading or writing. It's very important to have counseling staff with broad skill sets, right? So another thing when we think about assessment, I think it's obvious, we typically talking about the literacy skills. So that can be relative to part of the assessment, which would be relative to the individualization of interventions on the treatment plan. Also thinking about, learning style, which would be another way to think about real individualization of treatment plan and relative interventions. So a variety of different areas kind of there that Betsy's bringing up. So not only literacy, but also thinking about learning styles and how people process information. What's my clock? Additional considerations when we think about transfers, and it really comes back to, this is what we're doing across the board, from hello to discharge and transfers. Again, collaboration, and so those engagement aspects that we talked about earlier, and the shared decision making, that's all relative to transfer. I'm thinking about the person's motivation. And again, when we think about motivation, there's motivation to change, address my substance-related disorder, address my mental health condition, and then there's motivation for treatment. And not losing sight, I can be unmotivated for treatment. That doesn't mean I don't want to change. Just because I don't want to go to treatment doesn't mean I don't want to change. And understanding that those are different pieces. Frequently, we measure motivation based on whether or not people want to follow our recommendations. If you don't want to follow our recommendations, you're non-compliant or you have low motivation. Frequently, people may not want to follow our recommendations for other reasons, and they still might want to change or address their substance-related behavior or their mental health condition. So looking at kind of both aspects of that. Someone can be an intensive outpatient. They can be coming 10 hours a week. If they're struggling, can they come 15 hours a week? Can they come 16 hours a week? So we're really sometimes stuck on moving people from program to program compared to focusing on a continuum of care within a program. If I have intensive outpatient services, I could have anywhere from, say, a 12-hour-a-week service to a 19-hour-a-week service. If the person's not progressing coming 12 hours, can they come more hours per week compared to us transferring them to a higher level of care? And sometimes these are system design issues that certainly impact that, including funding. But even in outpatient services, can they come 3 times a week or 4 times a week if they're struggling coming twice a week? So can we increase service intensity within a level of care, which is what the criteria is intended to do, compared to feeling like we need to move people to entirely different programs or entirely different levels of care. It's like we have an outpatient program, it's 2 times a week. And if you're not successful 2 times a week, we transfer you to our intensive outpatient program that's 3 times a week. And it's
Scott,
10 hours. Yes.
we have about 2 minutes. We do have a question in the chat about combining IOP and PHP individuals in the same group and whether that's appropriate. Do you think you have time to address that as well
I
as
love that.
Okay.
Yeah, let's do that. That'll be our final question. So perfect, Aaron. So PHP and IOP, those are groups. Those are just services, right? And they're just really saying how often people are coming. The people in those services are relatively similar. In theory, people who need PHP might have more severe conditions than the people in intensive outpatient, but combining them would be, I think it'd be totally appropriate. There might be some unique folks who need PHP services who might not be highly functional because of maybe withdrawal concerns or biomedical concerns as far as their participation in group. But yes, the same thing, outpatient, intensive outpatient people being the same group. Yes, they're talking about the same issues. We're just talking about the frequency is more for intensive outpatient than outpatient. So yes, it would be totally appropriate. Just like 3.5 and 3.7, it's the same level of care. 3.7 people are getting more nursing and medical services, but if they were people who needed 3.5 and 3.7 could certainly all go to the exact same group therapy services because they're going to be addressing very, very similar issues. And the dynamics of group are no different in 3.5, 3.7, partial hospitalization, intensive outpatient, and outpatient. Group is group, right? We're going to work on our individualized treatment plan, we hope. All right. To be noteworthy. I don't know. I'm thrown off because I couldn't connect this morning. I'm still thrown off, Gloria. Anyway, looks like we have 1 minute left. Sarah, will we be addressing the documentation of the ASAM summary in future meetings with DDAP? I don't know, but if you put that in as far as a request, I'm sure we can probably touch on it one way or another.
We will. For now, the guidance that we have provided in the past is still valid for DDAP, but we hope to have more information next month to see if we can get more aligned with other payers. I think that's where the discrepancy is coming in. So for now, follow whatever guidance that your payer respectively requires, and we'll provide more information on that hopefully next month. Thank you, Scott. Maybe we'll pick up next month with the informed consent and then carry on from there, unless you don't need to do that. It's up to you.
I think we'll skip that. Next month we'll start with internal supports and supervision around the criteria, and then whatever other questions might come in, we can build on that from there.
Sounds good. Sounds good. Thank you, everyone, so much. Thank you, Scott. Thank you, everybody, for being on our call today. We really appreciate it. We will resume next month, first Monday in August, which is August 5th, with our TA series. So have a great Monday and a great start to your July. That concludes our webinar today.